Welcome back. As part of cardiac pathophysiology discussion, let's focus here on arrhythmias. Arrhythmias, abnormal electrical activity of the heart. Before we do that, we will talk about normal situation. Okay, you're looking at the conduction system. Here we start at the SA node, where the initiation of the electrical signal is the fastest. So this is the one that takes control. And anytime you see sinus rhythm, it's originating from the SA node. SA node is the pacemaker of the heart. So if it originates in the SA node, it is sinus rhythm. If you see atrial rhythm or ventricular rhythm, then you know that it's something other than the SA node. Okay. Anyway, so SA node initiates the electrical signal in the form of depolarization that spreads between the two atria, also reaching the AV node, which then takes the signal to the AV bundle or bundle of Hess. From here, the signal is taken to the ventricle through bundle branches. Bundle branches pierce through the interventricular septum and then branch off to become Purkinje fibers. These are fine branches. They are present throughout the ventricular wall on both sides. So that is how you basically spread the electrical signal throughout the heart. It's a one-way system. Okay, the conduction occurs from the SA node to the AV node, and then the bundle of Hess, bundle branches, and Purkinje fibers, and end here in the ventricles. All right, so this is normal, and the recording that you typically get, it's not from one cell, it's in general, all of the cells together. If you place the electrode on one or another part of the chest, you'll be able to pick up, or even without, by having electrodes on different parts of the body, like the ankles and the wrists, the 3-lead arrangement or the 12-lead arrangement. You will be able to see the electrical recording that repeats itself forever is what you call as electrocardiogram. So one electrocardiogram is shown in detail here, but you can see how these recordings are continuous. All right, so you have P wave, QRS wave, and T wave. So these are the three major deflections that you should be looking at. The distance between P and QRS would be PR interval, and then the QT interval. Those again help us determine if the distance between these waves is normal or not. Just one or two numbers. PR interval is about 160 milliseconds or 0.16 second. Okay, 16 second, 0.16 second. Then similarly, the QT interval would be about 350 milliseconds. Okay, so those are a few details. I'm sure there are many more details we could pick up as we go. Okay, so now let's talk about arrhythmias. These are abnormal recordings, abnormal electrical activity within the heart. Okay, so that's what it says, abnormal rhythm of the heart. So what are some abnormalities? The pacemaker could be other than the SA node. So it's ectopic pacemaker. Ectopic pacemaker is some other muscle fiber or a group of muscle fibers whether it's in the atria or the ventricles, but not the SA node. It could be AV node too. Okay, so spontaneous generation of impulses from elsewhere in the heart. So this is where you assume that SA node is initiating the rhythm. However, there may be an additional group of muscle fibers, either in the atrium or the ventricle, initiating its own rhythm. So there could be two sets of rhythms happening simultaneously. Abnormal pathways of transmission of impulses through the heart. We saw the pathway from the SA node to the AV node and so on, but here the pathway may be a different one, an abnormal one, that would include the pathway that basically circles within the atria, within the ventricles. Blockade of spreading of action potential through the heart. So this is where the conduction system is disrupted. Okay, it could be the drugs, it could be the injury to the conduction system, whatever it is, the signal is not able to be conducted from one part to the other. So the one-way street is now closed off somewhere within the conduction system. All right, so those are some possible abnormalities that one could expect. So now we will look at specific conditions and see what kind of variations they bring in. Okay, ECG changes one would expect with acute ischemia and infarction would be peaked T wave or inverted T wave. Okay, peak T wave is typically where the new muscle fibers that are added to replace the last ones are trying to generate signals. So that is where it could be the peaked T wave. All right, ST segment elevation or depression. Okay, so that's again, if you have lost muscle fibers, you would expect a depression. Elevation is when these new muscle fibers could be triggering elevation, ST segment elevation, produced by injury currents as depolarization spreads. Okay, changes in QRS complex. The frequency, the size, all of that could be different. Okay, then inverted T waves, if the signal is less than usual because of the loss of these muscle fibers or the formation of infarcts. Now, associated with pericarditis, hyperkalemia, acute myocarditis. So you have a bunch of conditions here: cardiac tumors, Osborn waves. This is basically J wave. That is the point, J point is right in between the QRS complex and the ST segment. Okay, QRS and ST segment is where the J point is. So Osborn waves. Positive deflection is what you see there. And what else? Seen in hypothermia. This is seen in hypothermia, okay? That is what you see here is ST segment elevation. All right? Then associated with left ventricular hypertrophy. Digoxin, hypokalemia. Note here it's hyperkalemia, ST segment elevation, and with hypokalemia, it is ST segment depression. Okay, so very typical. Okay, note of these two, and digoxin is the other one that would increase contractility, but then slows down the heart rate, and this is where it is ST segment depression. Okay, through ST segment depression is how you could slow down the heart rate. Okay, so now prolonged QT interval is where normal QT interval is less than half of the R2R interval. That's one ECG pretty much. Okay, one ECG is what, about 800 millisecond. And now if you have normal QT interval that is less than one ECG, that would be less than 400 millisecond. But here, in an abnormally long QT, it would be greater than 440 milliseconds. That's in men, and 460 milliseconds in women. All right, so what is it associated with? Increased risk of ventricular dysrhythmias. What causes it is where you're talking about. So long QT interval means decreased heart rate, correct? So hypokalemia decreases heart rate, hypomagnesemia does the same, hypocalcemia, hypothermia, myocardial ischemia, increased intracranial pressure, all of this, okay? Good. So normal QT interval is about 350 milliseconds, correct? So short QT interval has to be less than 350 milliseconds. So what causes that is where you're talking about paroxysmal atrial fibrillation. Okay, so short QT interval. Here, in atrial fibrillation, it could be long, it could be short, so all kinds of variations are possible. Ventricular tachycardia is definitely where you would see short QT interval. In other words, here the heart rate is greater than normal, okay? Greater than normal. In atrial fibrillation, there is variation, short, long, and orders possible. Ventricular fibrillation, definitely QT interval is less than 350 milliseconds. The syncope and sudden cardiac death is all where the heart rate is much greater, and that's where the QT interval would be shorter. Okay, so now let's talk about the individual structures within the conduction system, and how one structure may affect the electrical activity, how it deviates from the normal electrical condition. Okay, so what if there is sinoatrial node blockade? Okay, SA node blockade. Well, then what happens is there is no P wave. Okay, so now the new pacemaker would be AV node. So AV node initiates the electrical activity, the rhythm from the AV node. All right, spontaneous impulse in the AV node, new rhythm in the ventricle. So no P wave, but normal QRS and T wave. Okay, the rate, however, is going to be less than normal. Okay, SA node is the one that generates heart rate of 70 to 80 beats per minute. When AV node takes over, it goes down to about 50 to 60 beats per minute. Then you may have other parts of the conduction system assume the role of pacemaker if SA node and AV node are not participating, and that's where the heart rate drops even lower. Okay, so bundle of hairs, assuming the role of a pacemaker, could generate a heart rate of about 30 to 40 beats per minute, and that's very, very low for the body to keep up with the blood supply. All right, so now we turn our focus on AV node blockade. Okay, so SA node is fine, the rhythm is initiated, but AV node is blocked. Then the issue is the communication from the atria to the ventricles will not be taking place. Okay, so because of the AV node blockade, there would be disruption in the transmission of electrical signal. So that AV block could delay or completely block conduction from the atria to the ventricles. Okay, what could cause this is where you are looking at ischemia of the AV node, the AV bundle, compression of the AV bundle by scar tissue or by calcified portions of the heart, inflammation of the AV node or AV bundle, extreme stimulation of the heart by the vagus nerves, that is parasympathetic activation. Okay, so whatever the cause may be, the expectation now is that either there is a decreased heart rate or complete blockade of communication between the atria and the ventricles. Well, here we would organize the AV block into 3 types: first degree, second degree, third degree. First degree is the milder form. The second degree is somewhere in between first and third. Third is the most severe condition. Okay, so here PR interval is greater than 200 milliseconds. Normal is about 160 millisecond, right? And here it's taking longer, meaning slower heart rate. P wave has a corresponding QRS complex of normal duration. Okay, so it's just the duration that is increased. There is a P wave and then a QRS complex. All right, but it's just a delay. What could be the cause? Range from normal aging change to myocardial ischemia involving blood supply to the AV node, inferior wall MI, drugs affecting AV node conduction, digitalis and immunodurone. Those are the drugs that could be causing this delay or slowing down of conduction, basically. Okay, but everything else is normal. Okay, anything that enhance parasympathetic activity could slow this conduction process. And asymptomatic, meaning this is just a mild condition, no big deal. Second degree AV block. Okay, here the P wave without a corresponding QRS complex, all right, PR interval is much longer. Remember, 160 millisecond, but here it's 250 to 450 milliseconds, so longer. And there are a couple of different types: Morbid's type 1 block, Morbid's type 2 block. 2 block is a more serious kind. So maybe we should take a look at that first. So what happens here is there is a complete interruption, and it's a sudden interruption of conduction, and that's where you have dropped QRS. That means there is a P wave, but there is no corresponding QRS wave. Okay, without PR prolongation, usually at a point below the AV node in the bundle of His or in a bundle branch. So there is no PR prolongation, okay, somewhere at a point below the AV node or bundle of His or in a bundle branch. Okay, so it's the drop of QRS and no PR prolongation. Okay, without PR prolongation. So there is no prolongation, just the drop of QRS. Okay, so how does this compare this to Morbid's type 1 block? Well, here there is prolongation of PR interval until QRS complex is dropped. So there is prolongation of PR interval. Okay, here without PR prolongation. Got it? So This is a dropped beat. And this is dropped QRS. Got it? Okay. So Morbitz type 2 is probably at the verge of changing to third degree block. Okay. So second degree to third degree is where this transition could be. And again, this is asymptomatic. This could be going on, and the person may not be aware of this. Now the third degree AV block, more serious than first and second degree AV block. All right, complete heart block, complete interruption of AV conduction. Okay, P waves are present, and they're going to be faster than 70 to 80 beats per minute, and they are on their own without any link between P wave and QRS complex. All right, and look at the number of beats for a QRS complex, a lot less, okay, approximately 40 beats compared to the 100 beats. So more P waves, fewer QRS waves. All right, so for every 3 P waves, there may be 1 QRS complex. So what you think could be happening here is ectopic pacemaker distal to the site of the conduction block. Okay, so that's the one that's causing this QRS complex. All right, so now, so the block is usually around the AV node. Okay, and so it's not allowing the P wave to get through the AV node and the bundle of hairs and bundle branches and so on. But there is a new node or new group of cells that is initiating the QRS complex. All right, so that is the ventricular depolarization that you see less frequently than the P waves. All right, what causes this? Well, aging is one, okay, where you have the normal conduction system replaced by fibrotic conduction system that's not functional, okay? Good. Sinus tachycardia. So this is SA node beating faster than normal, okay, generating electrical impulse at a faster rate than normal. So typically, anytime it's over 100 beats per minute, that's when you use the term tachycardia. All right, so something is speeding up the action of SA node. It could be drugs, okay? It could be sympathetic stimulation or parasympathetic inhibition, okay? So, or the combination of both, okay? And just having tachycardia is not going to be life-threatening, all right? So now premature contractions. Premature contractions is shown here. You're looking at normal ECG tracing, and here you're looking at one additional P wave, okay, and so on. So that is going to be what we call as premature contraction. Okay, so here it's one cycle, and then here there is no, this is T wave and no P wave, then there is a contraction. There is a QRS complex, got it? So that is P wave, QRS complex, T wave. So this is usually where a pause is, okay? So then it becomes normal again. So that is typical of both atria and ventricles. Ectopic beat or extrasystole is common, and it could be atrial or ventricular. So once in a while you would see an extrasystole. All right, Now, atrial flutter is where the atria would generate more waves than normal. Okay, atria. So there is a muscle fiber. There are a group of muscle fibers that are generating, okay, more and more and more waves. Okay, but then they're not really P waves. They're flutter waves. They're small, and they're not going to lead to every QRS wave. So these are just noise type of waves. Organized atrial rhythm with an atrial rate of 200 to 350 beats per minute, 2 to 3 beats of the atria for every single beat of the ventricles. So that is the ratio. 2:1 AV conduction, where an atrial rate of 300 beats per minute, and ventricular rate would be 150 beats per minute. So it's caused by circus movement of the movement within the atria. That is, as I mentioned, a group of muscle fibers in one or another part of the atria, okay, just become excited and then start initiating these electrical waves. All right, electrical signal travels as a single large wave, always in one direction, around and around the atrial muscle mass. So it's basically within the atrial myocardium, often associated with atrial fibrillation. Maybe this is the early sign of atrial fibrillation. All right, so this is how it starts. And then one group of muscle fibers initiating these electrical currents will then change to multiple muscle fibers, creating the same type of electrical events. So one would be where you have more of these atrial electrical waves leading to QRS waves, whereas when you have multiple sites within the atria do the same thing, then you have what you call as atrial fibrillation. Here, the coordination between the atrial and ventricular QRS waves will not be present, meaning you have regular QRS waves in the atrial flutter, whereas in the atrial fibrillation, the QRS waves could appear sooner for some time, and then much farther apart, and so that is irregular. Okay, that is atrial fibrillation. Other conditions it's associated with include pulmonary disease, acute MI, ethanol intoxication, thyrotoxicosis, all right, cardiothoracic surgery. These are some conditions that could lead to atrial fibrillation. AFib is how you would abbreviate it. AFib would lead to other complications because the atria are generating these currents and not leading to the actual contraction within the atria. What happens is blood pools in the atria, and then that leads to the that leads to thrombosis, embolism, and then that could then in turn lead to stroke, coronary artery disease, and so on. So it's going to lead to many more complex conditions. All right, so supraventricular dysrhythmia. So this is always going to be above the ventricles. In other words, in the atrial chambers, most common cardiac dysrhythmia, AFib. Okay, it increases with age. 1% below 60 years of age to 12% in 70 to 84 years of age. Damming of blood in the atria, dilation of the atria. would lead to long conductive pathways, slow conduction. Okay, that's because you have blood sitting in the chamber that could make the path become longer and slow conduction because of the increased wall length, correct? And that leads to atrial fibrillation. Either no P wave or a high frequency, very low voltage wavy record. Okay, as I said, these are called flutter waves than P waves. QRST complexes are normal and irregular R to R interval. That is, the cycle length is not always consistent. Okay, each ECG would be of different lengths. Good. So the re-entry excitation is what you're looking at here. So initial impulse, okay, and re-entrant impulse. So what you're looking at is this is one-way conduction, and then it's supposed to end here, but then it circulates within the atrial myocardium. So this is how the current is continuously generated within the atrial, or the same thing can be seen in a ventricular myocardium as well. Okay, so this is the reason for a flutter or a fibrillation type of situations. This would be for one muscle fiber or one group of muscle fibers, whereas if it happens in multiple sites, that would change to fibrillation. Now we talk about atrial tachycardia versus atrial fibrillation. Atrial fibrillation is where I want you to see this. This wave here is not necessarily a P wave. This is flutter wave. So you're looking at QRS and T, but no P wave, QRS and T. And the distance between these two, are not the same. Between these two is shorter, between these two is longer. So R to R interval is not going to be, so this is what we call as R to R interval. So this is longer here, shorter here, and so on. Okay, so this is atrial fibrillation. What is this here? Atrial tachycardia is where you would see P wave. You see here P wave, and so it's there, but here it's missing. Okay, so it's going to be faster. Tachycardia again tells you that it is going to be much faster than the normal 70 to 80 beats per minute, but P waves are present and P waves are absent. Okay, good. So signs and symptoms of atrial fibrillation, again, asymptomatic, fatigue, palpitations could be another sign. Hypotension because of blood not getting through, syncope, angina pectoris, shortness of breath, orthopnea, all of that because of the blood not being ejected in a regular pattern. Okay, comorbid disease conditions associated with AFib would be hypertension, ischemic heart disease, hyperlipidemia, heart failure, diabetes, anemia, arthritis, chronic kidney conditions, chronic obstructive lung disease, and so on. Okay, so now let's look at ventricular electrical abnormalities. Okay, incomplete intraventricular block. That means we so far looked at atrial abnormalities. We are now moving into the ventricular part of the heart to understand what all abnormalities would be present here. Okay, one of them most dangerous that you, I'm sure, have heard of or know about in detail is ventricular fibrillation. okay? Ventricular tachycardia and premature ventricular depolarizations, ventricular standstill or asystole. So ventricular standstill or asystole is another serious one. If ventricle does not initiate an electrical signal for the ventricles to contract, then there is no way blood can be pumped, and so that would be cardiac arrest. Okay, ventricular standstill, that means there is some sort of injury, loss of the conduction pathway. That is when you have the standstill or asystole. Premature ventricular depolarizations, it's basically random depolarization, just like we saw with atria, premature atrial depolarization. Here it's premature ventricular depolarization, not a major one to be concerned about. Originates outside the normal conduction system randomly, okay? Ventricular tachycardia is where the rate to which the impulses are generated within the ventricle is going to be faster than normal. Okay, QRS complex is greater than 0.11 seconds, and rate would be 100 beats per minute or more. Ventricular fibrillation is where it's just like the atrial fibrillation. You have multiple sites within the ventricles. They all would generate their own impulses, and the ventricles are just moving. The muscle is fluttering, but nothing is going to be happening in terms of pumping blood. So blood cannot be pumped at this rate because these muscles are just making noise, but not able to generate the force of contraction that is required. Okay, so QRS complex is characterized by a heart rate of over 300 beats per minute and is usually not observable, is not compatible with life. Okay, so premature ventricular beats can arise from one or more foci below the AV node. All right, any part of the ventricles pretty much. ECG trace typically includes a premature and wide QRS complex with no preceding P wave. So that is just one random QRS wave, ST segment and T wave deflections opposite the QRS deflection, and a compensatory pause before the next sinus beat. So basically it corrects itself, and then no major concern here. Can be benign and self-limiting, or progressive and detrimental. There you go. If it's benign, it's okay. If it progresses, then it's like a flutter. Could occur as short episodes with spontaneous termination, or as a sustained pattern. 2 or 3 premature ventricular beats separated by 1 or more regular beats is bigeminy or trigeminy. Okay, over 3 is ventricular fibrillation. Here you go. Okay, a set of 2 bigeminy, a set of 3 trigeminy. But if it is more than 3, ventricular fibrillation. Symptoms include palpitations, near syncope, and syncope. A stroke volume decreased during premature ventricular beats, near syncope or syncope. Okay, because it's not able to pump blood. All right, now the conditions and factors associated with development of ventricular premature beats. What conditions cause the development of these premature beats, which may ultimately lead to become ventricular fibrillation? Okay, normal heart, arterial hypoxemia, myocardial ischemia, infarction, myocarditis, sympathetic activation, hypokalemia, hypomagnesemia, digitalis toxicity, caffeine, cocaine, alcohol, mechanical irritation. All right, like placement of a pulmonary artery catheter or a central venous catheter could initiate these premature beats. Okay, all right, now ventricular tachycardia is where the heartbeat is faster than normal, asymptomatic, common among over 60 years old individuals. Ventricular tachycardia is present when 3 or more consecutive ventricular premature beats occur at a heart rate of more than 120 beats per minute. Okay, so it could be a random, non-sustained paroxysmal rhythm, okay, just a random appearance, or as a sustained rhythm. All right, the rhythm is regular with wide QRS complexes and no noticeable P waves. So it's all contained within the ventricles. Causes could be iatrogenic, meaning some sort of manipulation, medical treatment, insertion of central catheter, mechanical ventilation. Those could trigger a ventricular tachycardia. Acute MI, presence of inflammatory or infectious diseases of the heart could be others. Now the last one, ventricular fibrillation. This is, as we know, is the most serious condition among all we have talked about. A sudden electrical shock of the heart or ischemia of the conducting system. There are circus movements because there are multiple sites within the ventricles where the muscle fibers are excited to initiate their own rhythms, okay, where many small portions of the ventricular muscle contracting at the same time, lacking coordination of contraction, pumping no blood or negligible amounts, unconsciousness within 4 to 5 seconds. Defibrillators are there for that reason, right? Irretrievable death of tissues in minutes. Ventricular tachycardia often precedes ventricular fibrillation. Most common cause of sudden cardiac death is ventricular fibrillation. Most victims have underlying ischemic heart disease. All right. Here is a good example of ventricular tachycardia. Okay, and now polymorphic. This is monomorphic versus polymorphic. Then ventricular fibrillation. Okay, the monomorphic is one similar pattern. Polymorphic is patterns vary. You can tell there are big ones, small ones, right? So the morphology, the size and the shape varies between QRS waves. Okay, that's because you're looking at the groups of muscle fibers that are active. Ventricular fibrillation is where you don't see a normal QRS wave. Okay, this is again flutter wave. That's why it's not able to initiate the pumping action of the heart. All right, here are some examples of several conditions we have looked at so far. And second degree is where you can tell there are more P waves not associated with the QRS waves. Okay, so blockade, about it's semi-blockade pretty much. Here, atrial fibrillation, we have seen other patterns before, other graphs before, and this is another one where you see the flutter wave instead of P wave, and they are to our interval is not consistent. Ventricular tachycardia is where it's faster generation of QRS waves, and not with the P wave. Then you're looking at ventricular fibrillation, flutter waves completely lacking QRS waves. Then third degree block is where you have many P waves and then the QRS waves. Okay, good. So this is the last slide. Okay, A good understanding of the basic details of arrhythmias is important for you as you would look at their medications and your handling of a patient with the anesthetic agents and how that may initiate or trigger the underlying condition to make it worse. So having this knowledge and having the medication and how to deal with these patients will all be very, very useful for you later. Okay. All right. Thank you.